So I'd like to try to get a slightly different perspective on this now and ask Ms. Rapola to weigh in. You know, you've had chronic fibrosing ILD with progressive phenotype. You know, I was wondering if you could tell us how your symptoms started, what your journey was to get to the diagnosis, and what got you to be evaluated in the first place.
So in 2008, 2009, I started training for a half marathon, and I, had been really active all of my life, and all of a sudden my times were getting slower, and so I decided I needed a coach, and so I got a coach, and my times kept getting slower, and so after about a 4-mile run one morning, I finally decided, I nearly passed out, and I decided, I probably should go to the doctor about this. So I went in to see my PCP, and she said, after a lung x-ray, she said, I think you have pneumonia. And she put me on a course of antibiotics, and it didn't resolve. And so she put me on another course of antibiotics. And then that didn't help. And so she said, well, why don't you go see an allergist? So I went off to an allergist, happy to report. The only thing I'm allergic to are tumbleweeds. And I then saw another physician friend of mine at dinner, and she was really worried because I was short of breath eating. And she said, I think you need to see a pulmonologist. And that's kind of when things started to change. So I saw a pulmonologist. He took a CAT scan of my lungs, and the immediate problem was that I had blood clots in my lungs. But I was really fortunate that he also noticed that there was fibrosis. And he said, I think this, so we dealt with the blood clots, and he said, we got to watch this now because you've had, and he called it an insult to the lung. And he said, we need to watch this now. And so for 5 years, that's what we did. We just sort of did watch and wait. And I did pulmonary function tests every year. So that's what got me to the doctor to start with.
So to the clinicians, I would ask, does this sound like a common story? And also to comment on the comorbidities and complications associated with chronic fibrosing ILD that you're looking out for when you see a patient like this.
Yeah, I think that is a pretty typical story that we hear. Patients, unfortunately, wait a long time from the onset of symptoms to get to their ILD diagnosis. They unfortunately see a good number of doctors before that occurs, and they unfortunately are misdiagnosed a few times before they get to the correct diagnosis. And so this is a pretty classic story that we hear.
Dr. Helmuth?
Yeah, I'll have to say amongst the rheumatic disease, maybe we're somewhat at an advantage or disadvantage, depending on how you look at it, since many of the other features of the rheumatic disease may present first. That actually gives us an opportunity to screen before somebody becomes symptomatic. So if you have rheumatoid arthritis and you come to medical attention because your joints are painful and swollen, then and you have no breathing symptoms at all, but it's recognized that some patients with rheumatoid arthritis and scleroderma and some of the other rheumatic diseases have interstitial lung disease as a complication. Then we actually have the opportunity potentially to screen and monitor for patients in an asymptomatic state and hopefully catch their progression sooner. But sometimes shortness of breath, even with a rheumatic disease, could be the presenting feature of their disease for patient. And unfortunately, that group who present with lung disease first are actually probably more likely to be progressive just because of the things that Justin described, that they may not be so symptomatic early on. So by the time they present with shortness of breath, they may actually have already accumulated a fair amount of fibrosis.
And I think that Dawn points out very nicely that it would be great if everybody just had one thing, but that's actually not the case. And so, for Dawn, she had the blood clots, the pulmonary emboli, as well as the interstitial lung disease. And we certainly see patients who present with other problems like pulmonary hypertension or coronary artery disease or peripheral vascular disease. So many, it would be nice if it was always one thing. And particularly with the progressive phenotype, one of the things that we're always looking for is it actually progression of the interstitial lung disease, or is it something else? Because it's very easy to attribute everything to progression of the ILD, when sometimes it's exactly as Dawn says, it's something entirely different, which may actually be even easier to fix. And so I think that as clinicians, a lot of what we do when we see patients who are not responding the way we had hoped is both say, are we treating it the right way? And then is there something else that's happened that is modifying the patient's course? And I mean, certainly Laura sees a tremendous amount of pulmonary hypertension in her scleroderma patients, and it can be very difficult, at least initially, to kind of separate what's progression of the interstitial lung disease versus what's perhaps emergence or worsening of pulmonary hypertension.
And sometimes it's both, just to make things more
Absolutely.
complicated. And yeah, and then our scleroderma population as well, I'll just mention, you know, almost all of them have gastroesophageal reflux disease, which is almost always the cause of cough. And then so if people have, you know, a progressive or nagging cough, the question is, everybody's always worried that it's their interstitial lung disease, but we have to keep some of these other features of the disease in mind, like reflux, which is actually a fairly common cause of cough.